Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Thank you, Debbie. It certainly is wonderful to have you all join us for NAHDO's 40th Annual Conference. This year's theme is NAHDO at 40, Data and Policy Spanning the Decades, and this will be our first of 3 Igniter sessions. This session is entitled APCDs and HIEs, Collaborating for Data Linkage, and was organized by NAHDO board member Katie Martin. I will be today's moderator. The other participants in today's session are Kyle Russell, the Chief Executive Officer of the Virginia Health Information, and Matt Enright, the Director of Analytics at DHIN. First, let me just tell you a little bit about NAHDO. Some of you may be visiting us for the first time and are not familiar with what we do. NAHDO is a nonprofit membership organization that is dedicated to the improvement of collection, analysis, and use of healthcare data. NAHDO provides a forum for state and federal agencies, researchers, and other stakeholders to share best practices and advance the field of healthcare data. You may have also heard talk of the APCD Council, and some have asked me, what is the APCD Council's relationship to NAHDO? The APCD Council is a program of NAHDO, and the APCD Council is a learning collaborative or community that is focused on the development and deployment of all payer claims databases. So let's first of all make sure that we are clear on what is an APCD. An all-payer claims database, or APCD, is a large-scale database, which typically happens at the state level, but sometimes is multi-state or just regional. And the focus is on collecting and standardizing healthcare claims, as you can imagine from the name, from various sources. What might you expect to see in an APCD varies by program, of course, but typically, as its name suggests, you will see medical claims and pharmacy claims. Those claims will have detailed information about the patient, the provider, and the service that was provided. In addition, APCDs, most of them at least, have enrollment data. So you can see who is enrolled in the various types of health plans, including patient demographics, such as age, sex, or location, and the type of health insurance coverage that they have. Some APCDs take one step further and maintain a master list of providers within their database. And of course, the heart and soul of the APCD is payment information. The reason that they were created in the first place was to identify the actual amount paid by each health plan for the services provided, not just the billed charges. APCDs also will be able to tell you the amount expected to be paid by the patient or others, such as deductibles, copays, and coinsurance. And recently, some APCDs have begun collecting non-claims payment data. This information is on payments that are made outside of traditional fee-for-service models and could include things like global payments or capitation. We also want to be clear what we mean by HIE, or Health Information Exchange. An HIE is a tool that allows healthcare providers, patients, and others to exchange health information across organizations and platforms. Key features of HIEs are that they have the ability to exchange data securely, that they are interoperable, which means that they work on various platforms and various settings. Some HIEs also function as a centralized repository for the information that flows through their channels. And of course, this gives patients control over who sees or who doesn't see their information. Now, today's topic is going to be focused on connecting multiple data sources. And I think it goes without saying, but I want to cover it anyway, why we should all be interested in the ability to collect or connect multiple data sources. Of course, there's no one data source that has all of the information that the users would like to have. And figuring out how to connect data from multiple sources can unlock the ability to answer new questions and in better ways. For example, If you can combine data from multiple sources like APCDs and HIEs, you can get a more complete picture of a person's health as well as the health of a community. We refer to this as a holistic view of health. Also, you can use data connections to improve public health, such as tracking disease outbreaks, prevalence, trends, or to evaluate the effectiveness of particular public health interventions. A third option is to drive quality and value. If you can analyze linked data or coordinated data, you can identify variations in care, measure provider performance, and pinpoint opportunities to improve patient outcomes while controlling costs. We presented a similar presentation this last month in September at Civitas, and we asked those who were in attendance at our session the following question: do you have a relationship with your APCD administrator? We wanted to find out if the connection is being made already between APCDs, HIEs, and other types of Civitas members. Not surprisingly, 58% reported that they did not have a current relationship with their APCD administrator. Now, that could be for multiple reasons, including that maybe there isn't an APCD administrator in some states. Well, we would like to do a similar poll today. We would like to understand from you whether you have a relationship with your HIEs, those who operate in your states. So, Charles, let's go ahead and put that poll on the screen. Just give us 1 second to load that up. Okay, so here we have the poll on the screen. Are you connected with at least one HIE operating in your state or area? And if you're not sure how to use the poll, on your screen, on the one side of the screen, you will see a little option there that's by the chat, and you can just click on polling, and there's an opportunity for you to vote in there. So it looks like people are figuring that out, so that's good. I'll just give that a second to populate. Very good. So we've got about a little bit, almost a little over a third of you have participated. We'll give this a little bit of time to kind of mature, and we'll talk about it in a minute. But I did not see any questions coming from the audience yet. So we will probably go ahead and move on to Kyle, and I will come back for questions later. I don't know, there would be a lot of questions about my part anyway, but let's, that polling, it should be active even while Kyle is presenting, and we'll just keep moving forward, and then we'll come back and talk about the results. So let's go ahead and introduce to you Kyle Russell, who is the CEO of Virginia Health Information. Kyle.
Hi, good afternoon, everyone. My name is Kyle Russell, and I am the CEO at Virginia Health Information, or VHI for short. And I am happy to be with you today to participate in NAHDO's Igniter session around how APCDs and health information exchanges can work together and work in harmony to support our broader communities, as well as specifically benefit public health and the public health agencies that we partner with. And so I know many of you, and you may be familiar with VHI within NAHDO, but just as a refresher, we are a private 501c3 organization created back in the early 90s. We were originally created to administer Virginia's hospital discharge database, and then have slowly added different systems that we run for the state over the years as data needs have evolved. And one thing that makes us more rare, I would say, is that we are one of just a few organizations that serve as both the statewide state health data organization and operate the state's all-payer claims database, as well as operating the statewide health information exchange. And so that has been a more recent change for us. You know, for a very long time, we were only a state health data organization, but that changed back around 2017. The HIE in Virginia actually used to be a totally separate organization and nonprofit called Connect Virginia. And due to a series of events, that organization needed a home at a time in which the Commonwealth of Virginia really wanted to build out a major component of the health information exchange. And so the stars aligned at that time for VHI to begin partnering with the health information exchange, but then over the next few years, have the HIE become part of the broader VHI family. And a lot has changed over that time, like what the HIE is and what VHI is between 2017 to now. Really, all of the different systems and programs that comprise the HIE and VHI have consistently grown and kind of reshaped what we are and what we focus on. So, there's the common saying like, every state APCD is a little bit different, and I would say on the HIE side, that is probably the same or maybe even more extreme. And so, a model that you will see is kind of the more common model is that a health information exchange will operate their systems and programs in what you might call a bundle. Like they kind of cohesively work together, and there may be a single portal or a single app, and it's presented as this is the health information exchange. Like all these things are synonymous, and you don't necessarily think so much about like, oh, this comes from here or this comes from there. And in Virginia, the way the HIE was set up was to be more programmatic because some things have mandates, some don't. Some sources are governed in different ways. It is a little bit more state mandate focused than a more voluntary, less state involved system may be. And so because of that, our health information exchange is very programmatically driven. And so that some people, they may not even know they're participating in the health information exchange. They may say, oh, I'm getting ADT alerts from the Emergency Department Care Coordination Program, or I submit all my data to the Department of Health via the public health reporting pathway, or I make sure my documents are in advanced care planning registry. All those different components, we're trying to make them more cohesive over time, but they very much live as a series of different programs. But they have like I don't think there's a single one that's not going through a pretty significant overhaul or expansion right now, which is pretty cool. Specifically for public health, I mentioned a second ago that we operate the public health reporting pathway. And the simplest way to describe this is that VHI, as the Health Information Exchange, connects with all the different private health entities, hospitals, labs, health plans, really, you name it. They all have connections with us, and then we facilitate data being submitted from all those different groups to the Department of Health to fuel essentially all of their different programs. And so this system is absolutely vital to supporting pretty much all the major epidemiology focused programs at the department. And there's not a single thing that we do for VDH that has as much of a day-to-day impact as this program does and has had over the past several years. So from the HIE side, there are multiple different programs that we will operate under VDH authority, or that data flows to VDH and is beneficial. But this is really like the most notable, I would say. On the APCD side, we certainly don't drive that same daily workflow with APCD like what is done on the HIE side. And I would say, I mean, honestly, like I think our uptick in Virginia with utilization of APCD for public health is not as advanced as some other states. Like we're trying to make up for that. And there's been a lot of really cool examples. There's all kinds of different groups that either work on behalf of VDH or provide reports for VDH that leverage this data. But for whatever reason, I think in a lot of ways, because the APCD is so big and cumbersome and can be a little bit harder to use, like the hospital discharge data has been a little bit more the go-to, and we're trying to continuously work with our health department, who's very interested in like how do we use this more, how do we leverage what's there, and that tends to be a little bit more of a growth area, I would say, like for us. But we've got a really cool project lined up. I just want to highlight for the upcoming year that we're going to do with HSRI on showcasing how APCD data can be leveraged for monitoring and reporting on chronic conditions and a little bit of disease surveillance across the Commonwealth. over that year, and we think is going to really drive a lot of interest that ties back to public health that we're really excited about. So I mentioned that we operate both the APCD and Health Information Exchange, and I talked about, well, this is what the HIE does for public health, and this is what the APCD does for public health. But you'll notice I did not give you an example of where they are both linked together and supporting public health. And that, unfortunately, is because we haven't gotten there yet. And so I have this sort of the wall set up here that feels like kind of very locked off. That's not to say that we don't see the immense value that comes from the linkage of claims and clinical data, because we see it all the time. Like, for instance, claims and clinical data together for HEDIS reporting enhances the value of both the HIE and the APCD, no doubt. And also, I will tell you, for the Health Information Exchange, there is so much value in being able to pull through the claims and encounter history, and the breadth of what's available for patients from what's in an APCD is gigantic. There's so much information that's there that's not elsewhere. And so we see the future of like, hey, we're going to be able to do this and it's going to be great. There's really two things to highlight on. It's like, well, why the heck then, if you've got the advantage of having this under one roof and you haven't done it yet, why is that? And so by far the biggest reason is that because for the APCD, that data, we made the decision a few years ago to pre-hash all the patient identifiers before the information comes through, or the submissions come through. That was done in an attempt to lure, or sort of suffice ERISA self-insured employers that may be more comfortable opting in if we did that. And the long story short, it really wasn't successful in the way that we wanted. And then what we're left with is a database that's really hard to link with other systems and have in a common master person index that we would need for the HIE. And so we've got to fix that. And so we are in the process of planning that out, and we will change that, and then that will remove the technical limitations that are there right now to make it much easier, and we'll be able to achieve these use cases. But that's something that we've been kind of working through. But the second that's really important, that's not a unique problem to Virginia, is that these systems and programs, they're just governed in very different ways. Like, Health Information Exchange data flow is very much, in from what I've seen, much more dictated by agreements than it is in the code. But for APCDs, there's a lot of requirements in code on how, if that data flows, what process you have to go through to do it. And a lot of those requirements may not be conducive at all to how you would want to share data within an HIE, like a data release committee that needs to sign off on every request, and information that's flowing upon request in real time in an HIE that may not always be compatible. So that's something I think we'll have to continue to look at, of like, how do we make the governance structure work so that we're not breaking any of the rules, but we can still kind of have both sides and users of different systems benefit. So the last thing I want to say is that, if you're an APCD administrator in your state, and you begin to have a conversation with, you have it's a totally separate Health Information Exchange, and it's like, how can we work together? I think it's a common concern has been, well, the Health Information Exchange is going to say, well, we have all these different types of data, and you just have claims. Like, why are you so obsessed with claims? And like, we can do this and this and this, and I just want to say, like, that is like, sure, like, claims are a form or one type of data, but there's so much more differentiation between an organization that may be functioning as a Health Information Exchange and someone that's a state health data organization or an APCD, beyond the type of data that you're working with. It's really way more about approach, and that the NAHDO state health data community is going to be a lot more focused on supporting research and supporting policy and strategic decision making with highly validated data that's gone through a process. And that's going to be much different than Health Information Exchange that may be more focused on, we've got to get real-time data out to make a clinical or care coordination decision, and we need to package things together to make that as meaningful and fit as well within the workflow as possible. and certainly there are points of overlap, but the fundamental like base touch point for who you're trying to serve, it's very different. And so just to say, it's really not like I said, it's not just about the claims or the term APCD. Like we're really more health analysis collection systems and providing like what APCDs can do with that kind of magic 8-ball service of being able to answer different questions is so valuable and can add so much value to different types of organizations. And so there's a lot of synergy there, and there's a lot that both sides are bringing to the table. And I just have this kind of funny steak picture here to say, in a lot of ways, we're all working with the same data or like the same process that's creating it. It's just one maybe, one constituent group maybe want something that's rare, it comes out right away, and you have someone that says, I do not want that, leave that thing in there, and like I want my steak well done, and I'm okay with like what comes with that, and it's a different preference for a different type of customer. And so again, we're all working with very similar data. It just may be taken out of the process at different points, and we specialize in meeting the needs of what our specific customers want. So, and certainly nowhere is that more true than public health. So again, I'm so happy to be part of the panel today. So much opportunity between APCDs and HIEs, and I look forward to giving a presentation very soon about how we've been able to do more linkage together. So with that, I'm going to pass it back to Norm and Matt, and happy to take any questions. Thank you so much.
Well, Kyle, we do have a few comments and questions here. So maybe just the first one, I think, is not so much a question, but a comment. I would like to get your reaction to Gurpreet's comment that claims data allow longitudinal analysis but lack clinical granularity. Clinical data provide rich clinical context like physician notes, lab results, et cetera. I think, but the inference is that you may lack breadth across providers or across longitudinality. What do you think about kind of that thought, or what else is missing from the clinical data that would justify, well, we should just use clinical data and forget claims?
No, I mean, overall, I would agree that you've got a lot more text-based information that, is in clinical records that you're not going to get in a more structured claim record. I feel like claims are definitely, they're collected and pulled together in a way that's kind of ready to go for analysis. We got to clean it up, certainly, but like structure is just more conducive to plug and play versus the clinical data. That is I don't think anybody really knows exactly what that means, right? Like it could mean a lot of different things, a lot of different types of data fall into that, what's clinical or not. So certainly something that's in a CCD that has a bunch of text, that's going to have context that's not in a claim. But if you were to compare it like a hospital discharge record or APCD record on an inpatient admission versus an ADT that's been exchanged by the HIE like 5 minutes ago about that same record, like the discharge, that claim record is going to have a lot more information than what is typically the backbone or like the core service for what's being exchanged with by an HIE. So it does kind of depend. I feel like there's a little bit more clear definition on like what's a claim, what's an APCD versus kind of what the bounds of what is an HIE and like what are the different types of data seem a little bit more undefined at times.
We have one more question here from Irvin Garcia from New Mexico. Is your data stored in the same data lake, or maybe is it stored in a data lake? And is that an internal arrangement?
It is not internal. So we have different vendor partners for different services. Because of the linkage issue, we currently don't have them in the same data lake right now. I fully expect and hope for that to change in the future one way or another or both. So that's definitely in the cards. But as of right now, they are separate. And at least we have different partners for each.
Yeah. And Irvin and I had conversations before about HIE data and APCD data, and what you mentioned in your presentation, this question of governance and access. I think HIE, the idea of access is sort of more on the fly, person by person at the time, where APCDs, it's more sort of like bulk. You're getting requests to use a lot of data for all at once. Do you have any thoughts as to how you will resolve that going forward?
Yeah, I mean, it's different. You hear workflow all the time on the HIE side, like it's got to work in the workflow. Like you need to be able to use it immediately, and like every second, or inconvenience that occurs, you've maybe lost someone wanting to use the system versus. Yeah, I feel like on the APCD side, it's more about like quality and validation. Like the terms that you hear and what you get beat up on, like is a little bit different for each. So for the governance side, like it would be harder, I think, to pull APCD data into the HIE workflow than vice versa, just how it's set up. We would have to have some sort of clear understanding with the release committee around like precedent for what types of use cases or supports like fall under a certain protocol, and then say anything that falls under that, like we facilitate in that way. But that's TBD. We haven't done that yet. Like exactly what level of rules would be put in place to do is a little bit of work in progress. But I think on a couple different projects that we're looking at right now, like there is a need for being able to batch requests or be able to have precedent prevail where you may not be able to support a use case if you have to go through a month-long review process. So we'll get there, but but I know some here and maybe Matt will touch this too. There's release committees for HIE sometimes too. So it can go both ways. Like it is a big governance discussion.
Great. Well, thank you, Kyle. And we're going to bring you back at the end for more questions.
Okay.
At this point, we're going to introduce Matt Enright, who is the Director of Data Analytics for DHIN in Delaware. Matt, go ahead. Let's go to your presentation.
Good afternoon. My name is Matt Enright. I'm the Director of Data Analytics at Delaware Health Information Network, also known as DHIN. I have the privilege to lead a team of data science experts to mine claims and clinical data to support healthcare improvement research and deliver what we call actionable insights. I have more than 20 years of experience in healthcare. I am a fellow of the American College of Healthcare Executives and adjunct faculty at Emory University. DHIN is the only HIE and APCD in Delaware for a population of just over 1 million people. Our HIE delivers over 18 million clinical results each year. Our APCD includes over 100 million medical claims, over 95 million pharmacy claims dating back to 2013. We're really the central nervous system when it comes to exchanging healthcare data between providers across the region. In my role as Director of Data Analytics, we partner with researchers and organizations that are interested in using our data to promote and improve public health and advance the triple aim of improving health outcomes, improving healthcare quality, improving the healthcare experience, and improving affordability. So some of the things that you really need to have in place that helps us and our ability to leverage both claims and clinical data together. Probably the biggest hurdle is legal. We've been working for many years with our data centers, including payers and providers, labs, et cetera, that give us the ability and authorization to use both claims and clinical data for analytic purposes. Definitely, it's been a long road to get there, but I appreciate the perseverance of my peers and working through and working with our data centers to get to this point. We also have, from a governance perspective, we've got a data access review committee. So anybody that applies for our data needs to fill out an application, and the data access review committee, or DARC, they review each application to make sure that the use case is approved to the statutory requirements that have been set forth. The third thing that's really critical as well is having a unified master patient index. So this gives us the ability to link both claims and clinical data for the same patient. So Matt in the clinical data is the same Matt in the claims data. Really important when you're pulling these two data assets together. So there's power in each of these data assets. So let's talk about the power of the HIE data. First and foremost, it's near real time. We get notifications for admission, transfer, discharges, other results pretty close to as soon as they're reported. And that's really powerful for certain use cases. It tells us those clinical results, as well as other conditions such as allergies, etc. So there's a lot of rich information in the HIE data. And it also tracks patient movement across providers in healthcare, across care settings, which can be important in studying different types of questions you want to ask of the data. One of the biggest known limitations of the HIE data is it's not as well structured. So you really need to look at the vast volume of clinical data and what do you want to actually pull out and put into some structured tables and data lakes so that you can actually use it for analytic purposes. On the claim side, the power of the APCD data, it's highly structured. That's why researchers like it so much. It really tells you what happened. Providers use it for billing, but it's also telling you actually what happened. They will bill for things after things occurred. It also tracks cost of care at the claim level. This is becoming a little more challenging with bundled payments and value-based care arrangements. So you need to be aware of that as you're looking at cost. Are there other things that you need to take into consideration so that you can actually have an apples to apples comparison when it comes to cost for some of these other arrangements? Some of the known limitations, there could be a lag time between 3 and 6 months. So the CDC came to us, they wanted to really assess the utility of using healthcare claims data to determine potential health impacts of PFAS exposure with public drinking water. So in essence, the CDC wanted to compare the use of claims data as a source for public health surveillance for PFAS to the use of clinical data for the same surveillance. From the study methodology, the CDC used claims dating from 2013 to 2019 and identified patients with chronic conditions using specific ICD codes. So after controlling for age, group, sex, year, and members living in the city of Newcastle, Delaware, were at a higher risk of having a diagnosis of type 2 diabetes, hypertension, stroke, coronary artery disease, and hypothyroidism. So you can see they proved that claims can be a very valuable resource for public health surveillance. The QR code is in the corner of my slide here if you want to read the actual article. It was published earlier this year, and it was really one of the first articles to show that you can use claims data. What I want to share is you pull the two data assets together, both claims and clinical data. You can ask the data a lot more interesting questions. You can do things like studies to reduce cardiovascular risk of a population. You could do a lot more detailed studies around healthcare disparities, et cetera. So it's really powerful if you have the ability to pull these two data assets together. So we did a recent poll at an HIE conference and asked the audience, what are the barriers they see to using APCD data with their HIE data? And what came out on top is the legal and regulatory barriers, almost at 50%. You can see a couple of them I'll highlight: the legal and contracting challenges, regulations, overly stringent data use requirements, policy conflicts at the state level, et cetera. So you can see that's definitely one of the biggest barriers. If you're going down this path, I would recommend exploring that and getting the wheels moving in the legal space first, because it could take some time to get there. The other thing that they identified was patient identity at about 17%. So having that master patient index that can allow you to see the same patients in the clinical data that are in the claims data is really going to help you pull these two data assets together. As I mentioned earlier, data quality and structure was another one that came up around 17% as well. So you really need to look at what are the key clinical information you want to pull out of the HIE and put it in a structured format so that you can use it in analytics. Some others that were highlighted, obviously cost is always top of mind. Making sure that the decision makers understand the use cases, fostering that collaboration between leaders of different organizations, and then of course staffing and governance could be a challenge as well. I sincerely appreciate your time this afternoon. Please, I'm open to answering any questions that you have. Thank you very much.
All right, thanks, Matt. We do have a couple of comments here in the chat from Gurpreet, who has given us the link to the CDC PFAS study. And then she says, the study demonstrates that healthcare claims are a useful source of timely, geographically refined data that can be used to identify health outcomes in communities with exposures to emerging and established environmental contaminants. Well, how do you respond to that comment?
Yeah, no, obviously Gurpreet is one of my lead data scientists on my team, has been instrumental in this study. And so, she was really just summarizing what the CDC was able to do. What I find interesting, their whole hypothesis was, can we use claims data to do a surveillance study the same way we do today with clinical data? And they were able to prove that, which is very powerful. But what I think was also a big learning, both for the CDC and others involved in the project, was you pull these two data sets together and you can ask even more interesting questions. So that's really where we're trying to go as a team, and look through other use cases that pull this two data sets together to really ask some complex and powerful questions.
Yeah. And we have a question now from Heather Hoganson, who asks, how is privacy of patients protected once the two data areas are linked?
So we have rules that our Data Access Review Committee has to apply, and they're slightly different on the claims and clinical sides. They're mostly aligned, but there are some nuances there. It is rare, but possible to get fully identified data as a potential output. Generally speaking, most of our data sets that we deliver that include claims and clinical data are either de-identified or limited data sets. They would include things like date of service, et cetera. Rarely do we release full identifiers unless it goes through the vetting process and we have proof from the requester that they have all the security protocols in place to be HIPAA compliant.
All right, great. Well, let's go ahead and bring Kyle back on stage with us. We've got just a little under 5 minutes left. I did want to first, before we get too far into this, let's take a look at our poll results. 53% of our attendees do not have a connection with at least one HIE operating in their state or area. First of all, is that surprising to you that there's the same level of disconnect with our community to the HIEs as there was from HIEs to the APCDs? Does that sound about right? Kyle?
I'm trying to think if it would be more interesting if it was different or not. I mean, I guess it is. It's like 50-50 on each way, or within a margin of error on each. I mean, I guess I thought it would have been the relationship, the yes would have been higher. So that makes me definitely feel like we got more work to do to increase that. Because, I get if you're like, who they are and you're not working together, that's a different thing. But like for just kind of knowing who they are and having some level of base connection, I think that's a good bridge for maybe NAHDO to help with for us to have more collaboration there.
Yeah, Matt, what are your thoughts on that?
Yeah, no, I would agree. I was a little surprised for this group that it would still be sort of 50-50 down the middle. But the good news is, Norm, you're here with your resources and ability to connect these people so that we can figure out better ways to partner, better ways to align some of our goals, and learn from each other. The more we combine our claims and clinical data, we're learning a lot on, where are things more structured versus not. So, I think it'd be a good opportunity to just continue to learn and talk to each other.
Yeah, I agree. I think this is something. I like Donald's comment. We know who our HI is. We just don't share data. So,
yeah.
but I do think
I get that. Yeah, right. That's like almost a separate thing. Right.
Yeah. But it all starts with like Matt just said. It wasn't this idea of if having a relationship so that you can have common goals and you can build towards something. And to be clear, the big issues are going to be technical issues and then also this governance issue, because they're just so different in their purpose and how they're set up that you've got to really think through all of that. We've got just a couple of minutes left, maybe a minute left. Why don't each of you just give us 30 seconds on your thought about what's next? Matt, what's next for you? And then Kyle, what's next for you?
Sure. Thank you, Norm. And thank you, Kyle, for partnering on this. Really, the next evolution at DHIN is we do have our data sets are in the same data area, but they are separate lakes. We are able to join them. We're really learning what are the key things people need to be pulled out of the clinical data and put into a structured format so that it's more usable. We hear a lot about GLP-1s. We hear a lot about blood pressure, cholesterol level, lab values, et cetera, and those results. I think that's where we're going to go next to see what kind of actual insights we can deliver as we learn more about structuring our clinical data. And that's really what we're focused on over the next 6 to 12 months. Thank you.
Kyle?
Yeah. I mean, our biggest focus is absolutely making it so that we're able to more easily link the APCD with other sources to both our health information exchange as well as to other programs that VHI operates. So we'll have that operational change. We'll have to work on the governance adjustments. And then we also likely will continue to pursue legislative tweaks for both programs over the coming years to make it a little bit easier in some areas for data to flow. So we have some use cases lined up that we'll get to, but right now it feels very much like the road ahead is very functional changes for just problems we need to solve to clear the landscape a little bit.
All right. Well, thank you both for your time. Just for our audience's information, next up, we have our Igniter session number 2. That'll be next week on Wednesday. This is Tuesday. Next week will be on Wednesday at 3 p.m. Eastern. And we'll hear a presentation about healthcare data informing non-compete regulation. So I think something a little bit different than we normally would see. And so it's kind of interesting to see that we're working data into the healthcare workforce. So again, we'll see you all again next week. And thank you all for your time. And it's fabulous to see so many people joining us. Thank you and goodbye.
Have a great day. Take care.